Hello, my name is Dr. Monika Patel. I am a chronic pain physician at the University of Florida in Jacksonville, Florida. And today we're going to discuss the medical management of a chronic pain patient. Just a brief overview for providers. This presentation was developed with funding from the Florida Blue Foundation and the Florida Medical Malpractice Joint Underwriting Association. For additional information, please visit pami.emergency.med.jax.ufl.edu to learn more. What is chronic pain? Chronic pain is pain that develops after an acute injury. So an injury that we would assume would heal on its own, but takes longer than expected to heal. And there's development of pain that lasts longer than the expected length of tissue healing, which typically is greater than 6 months of pain. It can also be influenced by environmental factors such as secondary gain, legal issues, pain catastrophizing. The way that we approach chronic pain treatment is multidisciplinary in nature, involving medications, rehabilitation, in some cases psychiatry, neurosurgical, orthopedic referrals, neurology referrals, interventional procedures. When a patient first arrives and is complaining of chronic pain, there is a basic evaluation that each provider must perform. First, their chief complaint, whether it's neck pain, low back pain, hand pain, knee pain, and history of present illness, the what, where, and why, numerical pain score, any past treatments they may have had for this pain, and any therapeutic trial effects such as ice, heat, any medications they've taken on their own, any type of self-treatment that they've performed, or any treatment they received at other clinics. And the functional impact. How has that impacted their work activities? Have they been off of work? And any fear avoidance behaviors such as falling, walking up and down stairs, and the goals of care. And goals of care would include how their expectations are regarding pain reduction or functional recovery. Then you're going to take a very good history of their current medications, particularly any type of opioid medications or medications related to pain, such as the number of pills a day and how they're taking their medications, which may not always be as obvious to what's written on the bottle, and any adverse effects such as sedation, confusion, constipation, any prior imaging, particularly of the area of interest, past medical history, past surgical history, social history, which would include a substance abuse history, which would be very pertinent if you are planning to prescribe opioids, a family history, which can also include a substance abuse history in the family, and then a physical exam, which would be a neurologic exam, as well as a focused musculoskeletal exam. Typically, for the chronic pain patient, we start with conservative therapy, which would include physical therapy, occupational therapy, and a durable medical equipment referral if indicated. Physical modalities include various exercises. With chronic pain patients, really want to start with low impact type exercises such as walking, core strengthening, isotonic muscle exercises. And particularly for patients who have been deconditioned, who are very sedentary, aquatic therapy referrals are very helpful, particularly because the water buoyancy helps relieve pressure off of joints in the lower extremities, lower back pain, and the therapist would be in the water with them to make sure that they're safe and that they're doing their activities correctly. There's passive and active stretching, which the therapist will teach them during the visits, and they can continue at a home exercise program. An evaluation and intervention for any activities of daily living that the patient may be suffering from. For example, if they have lower back pain, they may not be able to bend to tie their shoe or bend to pick up something from the floor. So they have different devices such as a reacher, which is pictured on the bottom of the screen there, where they can use the handle to pick up things without having to bend down, or use it to help them put on their shoes. And then what's always very important is that the patient continues this exercise program at home on a weekly basis at a minimum to maintain the benefits that were gained in physical therapy. A durable medical equipment evaluation is also very important, particularly if a patient has fear avoidance behavior due to falling, and that can include a wheelchair for long distances, as well as a walker. Different types of walkers offer different balance and support. A cane, again, different types of cane that can offer different levels of balance and support. And braces and orthotics, particularly for joint, feet support. There's also pain palliation modalities, which can be offered in physical therapy, which would be indicated by the prescribing provider if they would like the physical therapist to use any of these. And that would include heat, cold, or cryotherapy. That could be from ice as well as cold spray. A TENS or e-stim, which is a unit that is attached to the patient using stickers and will create a little pulsing activity, which helps a lot with pain distraction as well as relaxing the muscles in that area. Ultrasound, actually, unlike our diagnostic ultrasounds, ultrasound for pain palliation is used to produce a deep heat to the joint, which increases vascular dilation and can also help with pain. The ultrasound is not to be used over joint like abdominal cavities or areas where there's increased amount of fluid. And the TENS unit is not to be used in patients with pacemakers. Iontophoresis helps with tendinitis, particularly in areas where we do not want to inject cortisone due to risk of causing tendon rupture. So this is a device that's used to incorporate a anti-inflammatory medication like an NSAID that's on a medication pad, and the iontophoresis has a low level current that drives that medication towards that tendon or tissue to provide pain relief and decrease inflammation without having the risk of tendon rupture. There's also manual therapy and myofascial release techniques that can include a trained therapist providing release of specific muscle spasms or realignment of joints. There's also traction for discal herniation, which can also be beneficial depending on the severity of the spine disease, as well as massage. Additional physical modalities include alternative therapies such as yoga, tai chi, aromatherapy, herbal therapy, acupuncture. There's also a special type of rehabilitation related to work called vocational rehabilitation, and that's something called a work conditioning program, which is a structured progressive reconditioning that relies on endurance and physical fitness. So this is for someone that's in pretty good shape to begin with, but needs a specific type of strengthening for the type of job that they do. Examples would be police officers or firefighters that need to climb multiple stairs or carry a certain level of weight. Work hardening programs is for patients that have been off work due to an injury for a prolonged period of time and need to do job-specific work simulation. And then they can also address psychological or fear avoidance behaviors in the work setting due to their previous injury, and vocational issues trying to get them back into the workforce. The goal is to return to work after injury. There's vocational counseling for job placement and education for proper body mechanics, safe lifting techniques, and a healthy lifestyle so that they aren't re-injuring themselves. One of the biggest components of chronic pain management is medication prescriptions. There's been a push for non-pharmacologic treatment, multimodal treatment, as well as moving away from opioids. So we're going to talk about all the different pharmacologic therapies available. That includes opioids, antidepressants, anticonvulsants, NSAIDs, muscle relaxers, and topical treatments. So let's first talk about opioids. From 1980 to 2000, there was a net increase of 4.6 million prescribed opioid visits. It was a 9% increase. The illicit use of opioid prescription has risen faster than the legal use of this drug. And 50% of patients are non-compliant, typically requesting early refills, lost prescriptions, multiple providers of opioids. Now, this statistic is old. Since then, I think we've made gains to combat this by using the Florida Prescription Drug Monitoring Program and doing a better job of tracking how these opioids are prescribed, utilized, and any overdose deaths related to opioids. When a patient is started on an opioid, typically they sign what's called an opioid contract. These are some of the fundamental characteristics that are in an opioid contract, which are discussed with the patient and include take your medication as prescribed in the bottle, no disruptive behavior in the clinic or illegal drug use, which can be caught by urine drug screens or pharmacy calls or patient family calls, sort of describing the patient's behaviors at home. No early refill requests, no missed appointments for medication management, no replacement for lost or stolen medications, and inform the physician of side effects or medical condition changes. The patient must be open to submitting random urine drug screens or blood drug screens based on the provider's level of risk determination for the patient. And then if they are non-compliant, they can be disciplined by termination from the clinic, or in cases where the patient is also receiving other types of treatments from the clinic, then it would be termination of opioid prescribing for that patient. But still, they would have opportunities to have non-opioid treatments and other interventions in the clinic. Now, although these patients sign these contracts, there's little evidence that the opioid agreement improves compliance. Long-term opioid use pitfalls include side effects from the opioids themselves, which include central hypogonadism, which is a decrease in testosterone and sex drive. There's impaired immunity, particularly decreasing natural killer cell cytotoxicity, which can be problematic in the future. However, the evidence is still debatable on the long-term effects of the impaired immunity. There's also typical things that can occur with opioid use long-term. Opioid-induced hyperalgesia occurs when patients are on high doses of opioids, particularly morphine or oxycodone fentanyl preparations, at least above 400 morphine milligram equivalent on a daily basis. And what that does is it causes upregulation of the opioid receptors, causing hypersensitivity. And in that case, continuing to increase the opioid will cause increased pain, not following a specific region or dermatomal pattern, but a diffuse increase in pain, really not following their pathology of disease. So when you start to decrease or taper their opioids, they start to feel better. When you continue to increase their opioids, they start to feel worse. And that's due to that upregulation of the mu opioid receptors causing the hypersensitivity throughout the body. Opioid tolerance means that the patient has been on a medication for a minimum of 2 weeks or more, and now that dose is not as effective as it was before. Opioid dependence means that there's a physiologic dependence on the medication, so abrupt cessation of the medication will cause physiologic withdrawal symptoms, and that is including increased lacrimation, agitation, stomach upset, diarrhea, irritability, sweats. Opioid addiction is when a patient is violating social rules or standards to obtain opioid medications. Opioid pseudo-addiction is when a patient appears to be drug-seeking or aggressive about increasing their pain medications. However, in that case, the patient is undertreated, and when they are given an opportunity to be on a improved regimen, those addiction type behaviors are resolved. There's also tamper-resistant formulation, which have been targeted historically. Oxycodone and morphine preparations, there's different brand names that have come out recently, but they're more difficult to crush or dissolve, or when they are crushed or dissolved, the medication becomes inactive. So now we're going to talk about the different types of pain and which types of medications are typically used for the type of pain that the patient's describing. So burning pain, if you are going to use an opioid for neuropathic pain, the best candidates are those with an NMDA agonist receptor, and those include methadone and ketamine. So methadone treats neuropathic pain and cancer pain when the first-line agents are ineffective. So the first-line agents would be those that are non-opioids. It can also be used when tapering patients off of morphine or long-acting oxycodone preparations at high doses that have induced opioid-induced hyperalgesia. So as you're tapering them down, you can rotate them to methadone, and that will help with that hypersensitivity, sort of diffuse pain that they're experiencing. You do have to monitor for QT prolongation and sudden cardiac death in high doses. Typically, you want to have a EKG on file before methadone is initiated, and then monitor every 6 months, or when there's a dose increase, or if the patient is symptomatic, complaining about palpitations, or also if they're taking other agents that can increase their QT interval, such as tricyclic antidepressants. Now, when treating heroin addiction in a medication-assisted treatment program, the methadone dosing is different. It's going to be a once-a-day, very high dose, typically over 80 milligrams of methadone a day. When it's being used for pain, it's going to be less than probably 40 milligrams a day, and it's going to be every 6 to 8 hours prescribed in divided doses. Ketamine can also assist with hyperalgesia states and neuropathic pain. There's many different routes of ketamine administration. However, it can cause hallucinations, and that is also prevented or reduced when it's used with benzodiazepine therapy. But ketamine administration must be supervised and used with care under specialist supervision. For muscle spasms, there's many different options. For acute muscle spasms, something that a patient is complaining of for 3 weeks or less, the medications that are useful are cyclobenzaprine, methylcarbamol, metaxalone. But if those muscle spasms are chronic in nature, lasting for several months or years, then baclofen and tizanidine are better options for long-term use. Baclofen typically is not prescribed as needed, and the reason for that is because baclofen cannot be stopped abruptly, particularly in doses above 20 milligrams a day, because you can have withdrawals, which include seizures and death. Baclofen is a central depressant, so when it's abruptly stopped, then you have a central nervous system excitability, which can be very dangerous. So typically you want to tell your patients to slowly wean off their use and warn them of the side effects with abrupt cessation. Tizanidine is also a central acting muscle relaxer, but it can cause less drowsiness than baclofen. One of the side effects of tizanidine is it can cause low blood pressure. So in a patient that already has low blood pressure, you have to monitor with caution. Now, concomitant use of benzodiazepines and opioids was shown to have an increased incidence of overdoses, and the CDC guidelines in 2016 highlighted that. So anytime a patient is on both opioids and benzodiazepines, they need to be counseled on the side effects and also allowed an opportunity to have alternative therapies before those two medications are combined due to the risk of respiratory depression, sedation, and accidental overdose. Carsoprodol has a metabolite that's very addictive, and it's a potent anxiolytic and sedative, has a high abuse potential. It quickly causes physical and psychological dependence. It's not typically recommended for clinical use for those reasons. For arthritis pain, we typically think of our NSAIDs. However, they have GI, renal, and cardiovascular side effects, which limit their use, particularly in our older patients who might be debilitated, cachectic patients, critical illness, volume depletion, or protein deficient state patients. There were several studies looking at different types of NSAIDs and their cardiovascular risk. If a patient does have a significant cardiac history, recommend you discuss with their cardiologist before considering prescribing an NSAID for them long term. Also, if they have renal impairment or history of bleeding disorder or GI bleeding, really have to use that with caution. Tylenol is a safer option in those patients. However, if a patient has an alcohol use intake of 2 ounces or more, you want to limit their Tylenol use to 2.5 grams a day or less. If they have a history of liver failure or liver disease, you want to limit their Tylenol use to 2 grams a day. But for other patients, the recommended limit is 3 grams a day. And that is because sometimes patients will also get Tylenol from other sources without realizing it. So you want to make sure that the prescribed amount is lower than the maximum amount. So if a patient has pins and needles type complaints, particularly in the hands and feet or burning, the non-opioid options are anti-epileptic medications, gabapentin and pregabalin. It's an N-type calcium channel blocker. The side effects include sedation, swelling, weight gain, blurry vision. It is renally eliminated, so it does need to be renally dosed. Topiramate is a treatment used for migraine headaches. It has a secondary benefit of weight loss. However, it can cause some more cognitive slowing, fatigue, diarrhea. Carbamazepine is typically used for trigeminal neuralgia. It's similar to a tricyclic antidepressant in nature. It does have a long list of side effects, including agranulocytosis, aplastic anemia, affects hepatic function, which can affect how other medications that are prescribed to the patient are metabolized as well. And in rare cases can cause Stevens-Johnson syndrome. So a patient on carbamazepine does have to have regular blood work done to monitor for these side effects. Less commonly used, sort of last resort agents are listed here. And again, these agents have significant side effect profiles. Pain and sleep. A lot of the patients who have chronic pain have complained about difficulty sleeping or staying asleep due to pain. They might also have underlying obstructive sleep apnea, keeping them awake. So when you're thinking about pain and sleep, think about tricyclic antidepressants. The amitriptyline family is the first generation. It does have a more intense side effect profile than the newer nortriptyline, diazepam, second generation tricyclic antidepressants. These medications should still be used with caution in patients over 65 years old. It can also cause QT prolongation. Monitor for side effects including sedation, urinary retention, arrhythmia, cardiac disease, and weight gain. Patients that are complaining of diffuse tenderness, who may have fibromyalgia or myofascial pain syndromes, or neuropathic pain syndromes, peripheral neuropathies, you might want to think of starting a serotonin norepinephrine reuptake inhibitor. These include duloxetine. There is a minor risk of elevated transaminase levels, so in a patient with hepatic issues, you would want to monitor their hepatic function, their liver function enzymes. It can also cause GI upset, which typically they'll notice after their first or second dose. It can cause constipation. In some cases, it can cause suicidal ideation, so it's important to have that discussion with your patient, particularly the younger patients, about any mood changes that might occur with starting this medication, and to make sure that they stop the medication if they're feeling any of these suicidal ideations and contact their provider. For skin sensitivity, which would mean they have allodynia, or they can't tolerate their clothing touching a certain part of their body due to it being very painful. Consider topical agents. There are compound creams. However, these compound creams need to be formulated in a compound pharmacy, as it's not readily available in the hospital pharmacy or a typical commercial pharmacy. And these compound creams, when you prescribe them, you would have to also write the specific combination and percentage, and then they'll add that to a base cream for the patient to use. Typically isn't covered by insurance. There's lidocaine 5% patches, which can be prescribed. There's a generic version, which seems to be more accessible to patients. And that patch can be placed on the body part for 12 hours on, 12 hours off. If they forget to put the patch, take the patch off, the patch becomes inactive, typically between 12 hours and 16 hours. The 4% patch is available over the counter if they're unable to have access to the 5% patch. Diclofenac gel is now available over the counter. However, it can be prescribed as well, and it is approved for application over joints for arthritis type pain, particularly the knees, fingers, shoulders, and there's very little systemic absorption, so it's safer for urinally impaired patients. And then there's capsaicin, which affects substance P for the small C fibers and overall desensitizes that area. However, it does initially cause increased pain during application, so it's poorly tolerated. Now, for some of the patients, they may have comorbid mental health issues along with their chronic pain. And in those cases, a mental health referral is indicated. The psychological management is very important for pain catastrophizing. And pain catastrophizing is when a patient magnifies the pain, constantly thinks about the pain, rumination, and feels very helpless in controlling the pain. And when that cycle begins, it's sort of a self-fulfilling cycle where a patient loses motivation to get better and sort of falls into a dangerous area where they may use their medications for something called chemical coping, where their medications become an escape from this cycle of pain catastrophizing. Typically affects women more than men. Mental health can also help with different strategies for pain reduction, including operant behavior therapy, where there's punishment for negative behavior, cognitive behavioral therapy, which is developing positive coping skills, biofeedback, which include relaxation type techniques, breathing exercises, monitoring their heart rate, trying to slow their heart rate down or slow their breathing down. Guided imagery, such as this beach picture, a positive imaginary scenario. There's meditation, there's relaxation, hypnosis, there's also mindfulness. There's also addiction medicine referrals. So if you find a red flag sign of opioid misuse, you can consider referral for a medication-assisted treatment program. Typically, they'll use buprenorphine, naloxone, or methadone. You need an XDEA license, which is a special license that is granted to providers who complete additional training for addiction and prescription and prescribing of these particular medications. Other referrals that are beneficial are surgical referrals. For example, a neurosurgical referral may be indicated if a patient is experiencing significant bowel or bladder incontinence, progressive weakness or numbness following a dermatomal distribution. Orthopedic referral would be indicated if a patient's not improving with conservative treatments, injections, medications, and they also have significant osteoarthritis. On imaging, they may be candidates for joint replacements. Neurology referral may be helpful for diagnostic purposes, such as an EMG, nerve conduction study, or specific challenging cases for headaches or peripheral neuropathies. Additional imaging may be needed as well in your evaluation of the patient, including an MRI, CAT scan, X-ray imaging. And so references for this include Benzon and also the PAMI educational videos if you would like to learn more about this. Thank you for your participation in this workshop series. Take care.